Hello, hello, hello. I hope everyone had a great Labor Day weekend and it's so good to see you again. Ah, so as many of you may have noticed, and as we are letting more people into the room, I did not post a video for chapter 1 this week because I wanted to go over chapter 1 with you so that you can learn a little bit about me, a little bit about the class, and a little bit about what we're going to be doing. So I am recording this so that we can refer back to it later as needed. So let me just pull up our presentation. Okay, boom, here we go. So chapter 1 in our book, for those of you who don't have the book yet, the required text for the class is going to be Clinical Interview, the 6th edition. So please make sure that you grab it as soon as possible. But for this week, we are going to be talking all about what is the clinical interview in and of itself, and what is it that we are actually going to be doing in this class. That's going to be reviewed today. When we think about the many factors that go into the therapy and interview processes, the clinical interview is essentially that snapshot. It is the first time that you are going to be meeting with someone, and it is the first time that you are going to be gathering any and all information that you can. It's going to include doing, in some cases, psychological assessments to find out and to get a snapshot of where someone is and how they are functioning at that point in time, as well as a biopsychosocial, sexual, spiritual, or exam. I know it's a very long term, and actually we're going to be talking more about it next week or the following week. So don't worry about it. In many cases, we gather a biopsychosocial. However, I also find it very important for people that we also include a sexual aspect as well as a spiritual aspect, since those are things that help to make an individual who they are. And for some people, looking at their sexual backgrounds as well as looking at their spiritual or religious beliefs are very important to them. So this chapter, chapter 1, introduces you to all the things that we understand when it comes to the clinical interview. So by the time we're done, you'll understand what the clinical interview is and be able to describe it, identify the differences and similarities between the clinical interview and therapy. You'll be able to describe a model for learning how to conduct clinical interviews, apply the 4 essential multicultural competencies to the clinical interview, and be able to describe multicultural humility and why stereotyping is natural but inadvisable. So this class, even though we are remote, we are still going to have opportunities for us to get together to be able to practice what it's like to be in and complete a clinical interview. It's going to be an opportunity for you to take the skills that we learn and then be able to apply them. How this class will run is that you will have videos that go live for you that you will review. And then when we meet on Tuesdays in class, that will give you an opportunity for us to briefly go over what it is that we've learned in that chapter, and then be able to apply those concepts with a partner or a small group of people. So one of the things, or one of my goals in this class, is to make sure that you are as comfortable as possible doing a clinical interview. Take that with a grain of salt. Why do I say that? Because you are still going to be nervous when you are doing your first few interviews. When you talk about doing a clinical interview or clinical intake, understand that the first time or 2 or even 3, you may be observed as you are doing it. It's very nerve-wracking to have someone, a third party or a separate party in the room with us actually evaluating us. It's very nerve-wracking for most individuals. I know it was nerve-wracking for me, and it's most likely going to be for you. So take that into account. 2, when we start doing these clinical interviews by ourselves, it's still going to be a relatively new concept for us. And there's a lot of concerns that people carry with them around, am I asking the right questions? Do I have all of the information? What if the client is being defiant? What if the client isn't giving me enough information? What do I do if I can't get all of this information? What if I run over? Those what ifs and the should haves, could haves, and would haves that you may miss in doing your first few clinical interviews rather than looking at them as anxiety provoking and nerve wracking, we can look at it as a way that we are building a skill set. And it's also a way for us to be able to look at it as learning experiences. No matter how you look at it, when people come to see you to do the clinical intake or the clinical interview, they are interchangeable. Most people, when they come to the clinical interview, are not operating at their best. They may be sad, depressed, anxious, frustrated, angry. They may be in the process of detoxing. They might feel hopeless, helpless. They may be frustrated with the system. They may feel low. They may feel terrible about themselves. They might have poor body image, poor self-efficacy, poor self-concept. They may struggle to be able to put words together or to form sentences or to be able to communicate what it is that they need. They're coming to us and they're typically not going to be operating at their best. So always remember that whenever they step into the room, you assume a stance of privilege because you are seen as the therapist or the therapist in training. They will, whoever your clients are, they will always look to you as being a person who is all encompassing of understanding them, and the ways in which you go about connecting with them can make a huge difference. As we go through the class, we're going to talk about a lot of nuanced differences. You know, what it's like working with a child versus working with a couple or a family. There are similarities, but nuanced differences. Working with someone who is coming in for detox or rehab versus someone who is coming in for something like PTSD. There are similarities, but still nuanced differences. And we're going to have the time and spend the time together going over all of these things and talking about some of those nuanced differences. So who am I? I will give it to you in a nutshell. Again, my name is Dr. Victoria Pana, but please call me Victoria. I am a licensed professional counselor in both the states of New Jersey and Pennsylvania. I have been a practicing clinician for, goodness, now 9.5 years. I started off working with adults with intellectual disabilities or differing abilities in the state of Pennsylvania. I then started working with people who experienced complex trauma. Typically, they were veterans who also had sexual trauma or histories of sexual trauma, either before entering into the military or while they were in the military. I have worked in private practice now for about 5 years. I see clients who not only have complex trauma, but I also work with people who are experiencing grief and bereavement. I work with youth who are between the ages of 10 and 17 who are considered at risk. I also work with people who are pre and post bariatric surgery or weight loss surgery. That's the surgery where they modify stomachs to lose weight. And I don't typically do as much talk therapy as I do equine assisted psychotherapy, meaning that I have some clients that I see using Zoom right now because of COVID, but I also have a number of clients who come to a horse farm, one of the several that I work out of, and they see myself, they see an equine specialist or a horse specialist, and then horses are part of the treatment team. I've been doing that since April of 2011, and I absolutely love it. So my doctorate is in human sexuality with a clinical focus from Widener. I actually graduated in May of this year, and I have, I've done a lot of work with sexual related issues and concerns as well, especially with couples who are experiencing intimacy related issues. So that is a little bit about me. I can tell you that part of my master's program required that we had to do 600 hours of a practicum, which was all about observation, and we had to do 1,200 hours of practical work. Most of the work that I did, again, working with adults with differing abilities and their supports, my 600 hours was spent observing a number of different things, but I would say the first 6 of 1,200 hours that I had to do in order to get my practical license was to do clinical intakes. Again, nerve-wracking at first, but once you get into the groove and once you start becoming more comfortable through practice, it does get a lot easier. So, I want you to take a moment. I want you to close your eyes. In our text, it says, imagine you're sitting face to face with your first client. You've carefully chosen your clothing. You intentionally arranged the seating. You've set up a video camera in order to observe you interacting with the client, and you've completed all the introductory paperwork. As you have your eyes closed, I would love to know from you, what are the fears that you have about working with your clients? You can unmute your microphone and you can tell me any fears that you have. You can also put it in the chat feature, but what fears do you have about working with a client?
Mine would be probably not being able to relate to them and help them through whatever type of situations they're going. So, like, if I haven't been able to experience their life experiences, how will I be able to give them advice on how to, like, get through them?
Thank you for sharing. And that is actually a very common concern to have. How do I know that I'm going to be able to help them? How do I know that I'm going to be able to connect with them? It's also important too to think of it from this perspective. Whoever you are as an individual, if the person sitting across from you doesn't look like you or isn't around your age or isn't from the same background as you, how can you actually help them? Can it actually hurt you? The answer to all of those is we can still be the agents of change. When people come to therapy, there's a notion when the individuals come to us for therapy that we're going to fix them, which assumes that they're broken, and nobody's broken. They're simply used to doing something that is no longer healthy or helpful for them. So when they come to see us, we are going to be the agents of change. We are going to help them to learn new skills, to highlight and understand their strengths, and use those strengths to help them overcome their barriers. So, can we connect with them? Yes. Can we help them? Yes. In the clinical interview, depending on the agency and depending on the situation, in some cases, the person that if you are the person doing the interview, you may end up being their therapist by default, or your only job may be to do the clinical interview. So they meet with you and then they meet with someone else. Just depends on the structure of the agency. But can we work with them? Yes. Some people may not be comfortable. Maybe they want someone who looks like them. Maybe they want someone who's older because they want to get advice from someone like an auntie or an uncle or a grandparent, in which case you may not be the appropriate fit. Maybe someone wants to work with someone who's younger because they want a fresh perspective. So you have the ability to help support and you have the ability to be the agent of change. But that's a really great point. We also got a couple chats. Forgetting trauma, then inadvertently opening Pandora's box. Ron, that is also a very legitimate concern. I can share this with you. In many cases, depending on the individual, you will get one of two different types of individuals when they come see you. You'll get the person who you have to pull every single word out of because they're just not willing to talk. Maybe they're afraid. Maybe they've had bad experiences in the past. Maybe they are not ready to talk about it. Maybe they're just unsure of the whole therapy thing, right? So you might get the person that gives you, one or two word answers or, short sentences. The other person that you may get is the person who I kind of term in this way that they have word diarrhea. These are the people that just open up and the floodgates just open and you can't redirect them. They're very difficult to kind of bring back. They go off on these tangents and you're like, oh my goodness. These individuals may either A, be desiring someone who will listen to them, or B, they've been a part of the system for so long that they figure that the more they share their story, that they just kind of deflect on what the process actually is. It may also be C, that this is someone who has been holding in what's been happening and they're new to therapy and they just want to get it all out. That's it. So, when you think about the trauma in and of itself, especially in the clinical interview is typically one session that's 60 to 90 minutes. There are opportunities to ask questions about said trauma if they've experienced any. They may not be willing to talk about it, or they may want to talk a lot about it. In the clinical interview, as we're going to learn, you have the opportunity to set the boundaries of that, and you can get little snippets of their history, but we're not diving too far in. So if Pandora's box opens, throughout this class, we're going to practice ways to redirect people back. So you don't have to worry too much about that. Hold on. Kay's been trying to get into the classroom. For me, hopefully Kay will join soon. For me, I would say my fears would be not being helpful, or I'm not what they appear I should look like or be like. So when it comes to not being helpful, you might get someone who says that in the first session, and that's okay. That doesn't diminish your skills, and it doesn't diminish who you are as an individual. So I wouldn't worry too much about it, but I also don't want to diminish that fear, because that fear is valid. So understand that there may be people who find you helpful and there may be people who don't find you helpful. As far as, hold on, let me go back up. As far as not what they appear, or that you're not what they appear like I should look like or be like, I honestly, I might need a little bit of clarification around that, because I don't know that I understand what you're actually, like what you actually mean. So if you could clarify that either by unmuting your microphone or just putting in the chat box, that'd be helpful for me. Georgina, a defeatist attitude. Yep, you're going to get that, especially someone who has been through therapy before. People who are court mandated to have a session or to go through a series of sessions. Someone who has been essentially in their minds, they may feel let down from the mental health system. They may have a defeatist attitude. Part of the clinical intake or the clinical interview is that you're really going to be spending not only time asking them questions, but really listening. And for a lot of people, truly, genuinely listening and then reflecting back what they're saying can help to minimize that defeatist attitude. I agree about being worried about not being helpful enough. Also, not knowing how to get them to open up. So some people just naturally are guarded. And in that clinical interview, the way that the questions are essentially set out for you, you still will have opportunity to kind of go off the script a little bit, but then be able to return and kind of free flow as you need. When we think about the clinical interview, we're getting information. They're also going to have a packet of information to fill out before they come to the clinical interview. So you can always document that they might have filled out the paperwork before the clinical interview, but they were guarded when they were with you. One of the things that we do at the end of every session is what's called a mental status exam, or an MSE. In the MSE, if they're not really being open or they're being guarded, that's when you get to put into your notes about how you tried to work with them to help them to open up and they weren't able to at that time. There's also different question types that can help to elicit responses. Some people, especially if they're guarded, may need more yes or no questions and then allow them an opportunity to elaborate if they choose. Others need more open-ended questions. So we'll be able to figure out through practice which questions would work best. For me, it would be separating the personal experiences to the professional. Like if a client comes in with an issue I've been through as well, totally common. And something to think about is that what worked for us may work for them or may not. One of the things that we learn in our clinical training, not only starting now in undergrad, but especially when we're in our respective graduate programs, is how to be able to separate us from them, because we want to try to minimize transference and counter transference. So Is everyone familiar with transference and countertransference? Thumbs up, yes, or thumbs down if you're not. Do you all know what transference and countertransference is? Okay. So when we think about us in relationship to our clients, we want to try to minimize our clients putting stuff onto us and us owning it, and us putting our things onto our clients as if it is their own. So transference is where a client may take you, for example, as the therapist. You may remind them of someone in their world. So transference is where they take the feelings, the emotions, and the behaviors that they have towards that person, and they try to put it onto you. As a trained clinician, you will learn how to establish a boundary where you don't take that on, or you take it on only when therapeutically necessary. Typically, that is not in a clinical interview. Countertransference is where someone comes in and reminds you of someone in your world. And so you take your stuff and you inadvertently place it onto your client. Your thoughts, your attitudes, your behaviors, your feelings, you put it onto them. And in turn, they respond. Countertransference and transference are things that do happen in therapy. They are often things that we need to be aware of. And as you go through your training at Rowan, you will start learning the skills to not only better understand transference and countertransference, but also what to do as they arise. So if you have a client who comes to you for a clinical interview and makes you feel some kind of way, we all know what that way is. It just makes us feel some kind of way. If that happens to you, make sure that you check in with yourself as it's happening. And as soon as that session is over, you go directly to your supervisor and schedule an appointment as soon as possible to let them know, hey, I felt some kind of way with this client and I'm not sure how to handle it. As you are in session with them and this might be happening, something to think about is to go back to your script. As new clinicians, when we are going through the clinical interview, we are going to be given, and this isn't it, but let's say you get a piece of paper and it'll have a bunch of questions that you are supposed to gather from your client that you're working with. So if you're starting to feel some kind of way, just revert back to the questions that you need to ask of your respective agency. Okay, so basically it would be a racial issue. Okay, so I just want to make sure I have this correct, okay? Understand, I'm a white girl. I have a stance of privilege because I'm white and a woman and given my educational background. So just to make sure that I have this correct, and please tell me if I'm wrong, that that your fears would not be that you would not appear like what the client thinks. So the client might think that you're supposed to look or be something different than what you are based on your race. Do I have that correct?
Yes.
Okay.
And I've only said it because I've been exposed to it multiple times, but it hasn't when it first started happening, like I was upset about it. But now it's just, if that's what they choose, that's what they choose. Some openly, when I go to do home care, they're like, no, and they won't directly say it because I can't leave until the nurse comes to find out why they don't want it. And that's when they'll say, I was looking for someone of different skin tone.
Well, first of all, I'm very sorry that happened to you. That's not okay. Second of all, I can't say that I even understand what it's like because I haven't been in that specific position. So in mental health and in speaking with a number of people in my cohorts, in my programs, and also in my peer networking groups, I do a lot of peer-to-peer support for therapists. I know that is unfortunately not uncommon in some areas. How my cohorts and my peers who are women and men of color, how they chose to, or how they did handle it, was that they would have a conversation with the individual and essentially tell them one of two things, depending on what the circumstances were. One being, you can reschedule your appointment, but we can't guarantee. If you want someone with a different background, we can't guarantee that you will be able to get someone with a different background, or that you'd be able to get it in a timely manner. So if you're, willing to continue, I'd love to work with you. Otherwise, we can wait until, if there's that availability. That's the key thing, because there might not be availability. Second, they would use that as a learning opportunity to get to know the client better and for the client to explain potentially some of their concerns. Most of the concerns, if the client was willing to engage in that conversation, most of it was based on ignorance more than anything else. And that's just what's been reported to me. So it's coming from second and third hand information. So unfortunately, clients are going to have a number of issues with a number of things. It's going to be race or ethnicity. It could be based on weight. It could be based on age, national origin, differing abilities. It could be based on so many different factors. I have known people, unfortunately, who have physical limitations and are wheelchair bound, who clients didn't want to work with because they were in a wheelchair and they felt too bad for them. I've known people, including myself, who have been told that they don't want to work with us because we are too overweight. I know people who have accents where English is not their first language. Their national origin is from outside of the United States, and clients didn't want to work with them because of their accents. So understand that our clients may find things at fault with who we are. A, that doesn't define who we are as professionals. B, it's okay to end the session, and I would have this conversation with your supervisors first. But given how bad it becomes in the room, it may be best to end the session, especially if there's a lot of aggression or anger that is coming from the client towards you, or a refusal to do anything further. You can try as much as possible to get information, but if they're refusing to talk to you because of said issue, then it's okay to terminate that session and go directly to your supervisor and explain to them that the session was terminated because, and here's what I did to try to engage the client, and that they were unwilling or unable to continue forward. I would also have a conversation with your supervisors, again, before you even do your first clinical interview, and let them know, hey, listen, these are my past experiences. How does your agency handle when these things arise? In the age that we are in today, we have people who are more open and willing to work with people who don't look or act like them. There are some people who are not willing to engage in that. Agencies typically have protocols set in place to handle all of those issues and concerns. So I would definitely have that conversation beforehand. Understand that as agents of change, we cannot work with everyone. There will be people who we cannot work with. It might be from different diagnoses. It could include different behaviors. It can include a number of things. And as you go through your professional training, you will find out which populations you definitely can work with, which populations you can work with if you had the right training, and populations you cannot work with at all. For me, again, just from my experience, I cannot work with people who are sexual offenders. I've done a lot of work with individuals who have been on the receiving end, whether it's directly, indirectly, or vicariously through sexual trauma. So I cannot work with people who are offenders. That is something I have attempted to work through. It is something that I know that I have spent a lot of time, doing introspection. So any agency I went to go work for, I would let them know I can't work with this population. So if you work with them, I'm not the right fit for you. As you go through your training, you will figure that out. But unfortunately, you will still have people who may who may not want to work with you because you don't look like them or act like them or can understand them. And that's unfortunate. I'm sorry that happened. And that's kind of the best answer that I have right now. I'm really sorry. We're going to get back to this icebreaker. We're actually going to do it at the end. So my teaching philosophy, first and most important thing that I want you to get from this class, or at least understand, is that this is a collaborative learning environment. I learn as much from you as hopefully you will learn from me. As we are training to be agents of change, part of that change is understanding from a broader perspective. So first of all, thank you for sharing that unfortunately that you have had these racial biases happen. I know that they happen. I don't necessarily always agree with why they happen. I never agreed with why they happen, but I recognize that they happen. But your lived experience is different from mine in many ways, but we also have similarities in that we've both had bias brought against us. And they're different biases, but they're still biases that have been brought against us. So every time we are able to share and every time that we are able to communicate, we get to know each other better, and then we get to broaden our perspectives. Think of if you've ever taken a sociology course. Intro to Sociology or Soc 101 says that there's this term that's called the sociological imagination. It's a term that was coined by a gentleman named C. Wright Mills in 1959. Sociological imagination essentially says that we want to make the familiar strange. And part of making the familiar strange is through this collaborative learning environment. I learn from you as much as you learn from me. And the more that we're able to share and engage and communicate, we broaden our perspectives so that it's not just our narrow focused world, but rather a world that is full of enriching stories and narratives that can help us to understand things from different perspectives. I also believe in epistemology, that people come to learn what they know, and that it is done typically through engagement. I'm a proponent of essentialism, where I believe in teaching the basic skills that are proven to be needed in society over time. So I provide the skills, but then I also believe in behaviorism, where we can cultivate behaviors that are beneficial to society. So part of my job is to not only give you the skills, but also to help you with practicing so that you can start learning those behaviors. I'm also a proponent of constructivism. This is education that helps to shape your worldview, you meaning the student. So we're going to cover a lot of stuff in this class based on our textbook, but as you share stuff with me, I tailor the class based on where the needs of the class are. If no one in the class wants to work with veterans, for example, many of my teachings are not going to be working with veterans, but if someone from the class wants to work with a veteran, I'm going to make sure that that is incorporated in. So I try to meet you where you're at. And whatever populations you believe that you want to work with, I tailor the class and the class activities to meet that. I'm also a proponent of humanism, where I foster every student to their fullest potential. So through your practice and engagement with your fellow classmates, I offer you constructive feedback, never constructive criticism. At least my intent is to not be critical. My intent is to help you to relax, is to not only take the skills that you've learned and then be able to apply them, but apply them in a way that is now going to be beneficial for you and can help you to develop as the best clinician possible to do clinical intakes. Something to think about too, as we go through the skills in the clinical intake, many of these skills will overlap with doing therapy, which we're going to talk about momentarily. So again, what is the clinical interview? The clinical interview is a flexible procedure that essentially will be an assessment of where a person is at that moment in time. It's like a snapshot of how they're functioning. And also, we help them to find out what's going to be the next thing that's going to be best for them in order to facilitate change. That might mean individual therapy, group therapy. If they haven't had a physical, going to their primary care physician or PCP or family doctor to go get a physical to rule out any medical related concerns. Might mean meeting with a psychiatrist and or psychologist to talk about some deeper rooted concerns they may have and maybe even think about medication. So the clinical interview is an information gathering session where we get this information and then we get to take this information and then help to construct what the next steps are going to be. It is typically a flexible procedure, and something to think about in case you didn't know this. The first clinical interview was actually something that was constructed by Jean Piaget. If you've never heard of Jean Piaget, you will hear a lot about Piaget throughout your next few years at Rowan and beyond. But Piaget is essentially responsible for how we look at the clinical interview. Back in 1920, he was working with another gentleman to take an English test called the Stanford-Binet test, that test for intelligence. And he was taking the Stanford-Binet and he was translating it into French from English. And he wanted to, he developed this interest in working with children and how children think. He was interested in how children think and how they conceptualize the world based on their intellectual ability and how they've experienced the world around them. So part of what he started doing was incorporating asking these specific questions in order to get a better understanding of how children conceptualize the world around them. And he started asking these questions in a more standardized way. So now you're using a standardized instrument to gather information, and you're now doing an interview, which is where you are gathering this information, asking questions, and getting responses. So you're getting this narrative, which is more like qualitative analyses, and using an assessment, which is a quantitative analysis, which helps to enrich this understanding of the child. And he found that you can now take that and you can replicate it with other people. So now we're focusing on adults, and we're focusing on couples, and we're looking at it from a family perspective, and we're now looking at it with different populations. So Jean Piaget said that you can include this standardization with a test and this spontaneity with an interview. And that's essentially a clinical interview. And over time, it has developed into this information gathering session where you are getting a snapshot of where your potential client is functioning at that time. Your text describes a clinical interview as a complex and multidimensional interpersonal process that occurs between a professional service provider and a client. The primary goals are an assessment and helping. To achieve these goals, individual clinicians may emphasize structured diagnostic questioning, spontaneous and collaborative talking and listening, or both. Clinicians use information obtained in the initial clinical interview to develop a case formulation and a treatment plan. So, how are clinical interviewing and counseling similar or even dissimilar? Well, let's talk about the similarities. The clinical interview is essentially the first stop that someone takes. So you are essentially going to be the face of what the person who is coming to your agency, you are the face of what the agency is like. So that intake interview, that clinical interview, is the first snapshot that they're going to have to therapy. And it's usually considered an assessment procedure because there are certain pieces of information that you gather during your time together. And in some cases, there's going to be a lot of questions to gather this information, or there's going to be a lot of redirecting the client back to make sure that these pieces of information can in fact be obtained. There's also some theoretical orientations that help to minimize it as a truly formal assessment. So if we were giving, for example, the Beck Depression Inventory 2, there's a script that you read and there's certain questions that you ask. In a clinical interview, you can administer the Beck Depression Inventory 2, but that interview process, you may have a script, as I had mentioned earlier, as you are, starting out as a new clinician. But over time, you'll be able to become comfortable with the types of questions that you're going to be asking. So you're going to go less from a script and more informally. Like, wow, that sounds really tough that, you had to get 3 jobs in order to pay for your bills. Where are you at now financially? Are you in a more stable situation, or is your financial situation still dependent on these 3 jobs? That's going to be helpful in you understanding from your client whether therapy right now is going to be okay for them financially, or do they need a sliding scale, or can they go through their insurance? It also helps you to understand What are the parameters and timeframes that my client actually has in order to seek therapy? Is in person going to be most beneficial for them, or do we need to consider remote given their time constraints? So you go a little bit off the cuff once you become more comfortable with it. Sometimes therapy is just one session, so it can include everything. Those are different theoretical orientations that you will learn in other classes, and they are not ones that are used as much today. So, something else, let's go back for a second. Something else to think about too is in the clinical interview, in you being the first contact, that may be the start of your relationship. In some agencies, they don't have a separate person who does clinical interviews. So you're the person that they see, and now you're going to be the person that they work with. In other situations, you may be the first person that they see, and they're large enough that now you take that information and you connect them with an appropriate social worker, psychologist, counselor, or marriage and family therapist who can work with them the best. So it just really depends. Think of the clinical interview versus the counseling session this way. Clinical interview is one session, maybe two, but usually one session that's about 60 to 90 minutes long. The therapy is typically going to be a longer duration of time, typically 45 to 60 minutes, at least once a week over a period of several months. When we think of the nature of an ethical professional relationship, we need to be very direct and explicit in our agreement or in our informed consent to provide services. You can't go beat around the bush with this. You need to let them know that this is why they're here, that this is what the role of the therapist is. This is what the role of the client is. These are the expectations of the therapist. These are the expectations of the client, that they can feel free to let you know within 24 hours that they're not going to be able to make it to a session. If not, they're charged a fee, and this is the fee amount. That if they refuse to come to so many sessions or cancel so many sessions, that they will be terminated from therapy, and then they can, come back through the intake process again. You have to be very explicit as to what your agency's protocols are in working together. Typically, that will not only be reviewed like you are doing now, either through a virtual session or one-on-one or in a small group or face-to-face, but it's also going to be done with electronic paperwork or regular paperwork. There's a photocopy of it that is then made available to the client. If the client chooses not to take that paperwork, you have to note that in their file. You also have to be explicit about the payment amount or compensation. So the clients need to know that you have to pay before the session begins and that you are charging them X amount, which is either based on their insurance copay, based on a sliding scale fee, or it is based on whatever the fee for service is. One thing I will say, and not every agency is on board with this, this is just from my personal experience. I don't do any sessions for free. I don't. I'm in a position where I do sliding scales. The lowest amount that I will charge is $5. And there have been some situations, even recently, especially in the world of COVID, where some people weren't able to do $5 that week. So I would charge them $1 and then the other $4 over so many sessions. The reason I do that is because of this reason. If you give away, in my experience, when I gave away services for free, my clients did not take the services seriously. They would cancel more often. There were no shows more often, and they didn't value the time spent together in session. And they also didn't value the time between sessions. When you think about therapy, there's a lot of work that happens in that hour, for example, that you're together, but there's even more work that happens in that time span between sessions. For me, I'm a person that I give homework, and I found that when I gave away sessions for free, that homework wasn't done. I can actually only think of one client who ever did homework. So even charging $5 was and has been enough for my clients to be able to do the work, and they took it seriously. It's also important to talk about a power differential. There's a power differential in us being in this class, that I'm the professor and that you are the students. No matter how I try to make it as collaborative as possible, there's still a power differential in that I'm the professor and that you are the students. There is an expectation that I have of you, and there's an expectation that you have of me. As collaborative as I try to make the class, there's still that power differential that occurs. And we have a chat. Oh gosh, absolutely. Ask any question you'd like.
Hi, so going back to like the payment, I know that like with my personal therapist, like I don't give her a copay or anything because my insurance covers it, but like do you know how that works with like the insurance and stuff like that? Like do you have to get on insurance? Do you only accept certain, like I don't know how all that works.
That's actually a really great question. So it depends on the insurance provider. So there's different types of insurance. There's Medicare, Medicaid, PPOs, and HMOs. Without going too far into it, because I know that it is covered at another class at Rowan, it really just depends on the insurance company. Some insurance companies, depending on the insurance that you have, will require a copay. Others do not. Some will, not cover the insurance, or that what some insurance companies do is that they have a deductible. There's a certain amount that you have to reach before it's covered 100%, which is what I primarily do. So my clients will come to me. We have they pay for their session. Let's say it's $100. Okay. They'll pay their $100. And at the end of the session, I provide to them a bill. It's called a super bill. And in that super bill, I provide to them, it has how much, it includes their treatment codes, what their diagnosis or diagnoses are. It also includes what kind of session we had, if it was individual, family, couples, or group, and then how long we met. So I provide them that super bill information. I also include how they paid, whether it was by check or card or cash. If it's a card, I include a photocopy of the receipt of their bill that was paid, that my clients then take that information and remit it to their insurance companies to get either reimbursed or have that money go towards their deductible. So every insurance is different. It just depends on the insurance itself. But that's a really great question. The next part of the ethical professional relationship is that you let your clients know about your background. It's important that you talk about, that what your professional experience has been, or your educational experience. For you as therapists or psychologists in training, it's really important to let your clients know, I am a psychologist or a therapist or a social worker or a marriage and family therapist or counselor, however you choose, whatever it is that you choose to go for, I should say, for your master's or doctorate. But you let them know that you are a student in training. This is where you go to school. And at the agency, this is who your supervisor is, should they have any questions. You don't want to not mention that information, because if something does happen, then it could kind of fall back on you as part of not giving the full informed consent. There's also some professional distance and associated relationship boundaries that have to be set forth. For example, there's a notion of dual relationships. Depending on where you live, you may be one of the very few therapists who are able to be seen, but yet you frequent someone's restaurant if they're a restaurant owner, or you two go to religious or spiritual services or volunteer together. So if there's a possibility for that to happen, then something that you can talk about in your initial session is, in the event that I see you outside of the session, do you want me to acknowledge you or not acknowledge you? If I am to acknowledge you, how do you want to talk about how we know each other? That is very common with self-help programs. Absolutely. How, in what capacity do you want to exchange pleasantries? I have encouraged for some of my clients where there could be a potential dual relationship, and again, this is me, I have encouraged that some clients, let me first off start off by saying that some clients, they don't want to be acknowledged at all. So if I see them, I keep going. Other clients, we can do a hand wave, keep it going. Other clients I've had where we've set a boundary, and then if they see me out in public or they see me somewhere, they then start gushing to whoever they're with or whoever's around us about how I'm like I'm their therapist, and they go on and on. So it's as much of a protection for them as it is for you. So I've always told my clients, I don't feel comfortable reporting our therapeutic relationship in public. So if you choose to do that, you can be the one to initiate it. I cannot go into specifics about your case, but it might be best to think about either just doing like an acknowledgement with like a head nod or a hand wave, or we just keep going, whatever is most comfortable for you. Kay says, wouldn't you just wait to see if a client acknowledges you in public and then respond? It's actually a very good question. I'm going to say no, and I'll tell you why. This was something that we were taught. So my clinical mental health counseling degree, my second master's, is from Villanova. And that was one of the first things that we talked about when I entered into the program, was about dual relationships. As you know, my doctorate is in human sexuality from Widener with a clinical focus, but it's still human sexuality. So I've always had the conversations with my client, and there was actually 2 clients that I had in my career that I've forgotten to do this with. I ended up seeing one while I was out at a store in Center City, which I never go shopping in Center City, but I happened to be at a store. We were shopping for bachelorette items for a friend of mine, and I saw the client in the store, and the client was screaming like you had seen, I don't know, whoever's a professional sports athlete or an actor or an actress that is like, the next best thing to sliced bread, like screaming, oh my God, oh my God, oh my God, there's my therapist, blah, blah, blah. And in the middle of the store, as I'm holding a whole bunch of items that are of a sexual nature for a party, bachelorette party, this client is trying to have a therapy session with me in the middle of this store. And I kept trying to redirect, but the client kept trying to talk about their problems and was talking about the reason that they're in this store, and just, it was extremely inappropriate. So I went back, and I would like, after this was over and we left the store, we didn't even purchase anything. I put it all back and we left. At our next therapy session, I had to have the conversation because my countertransference came up, and I had become quite upset that this is what took place, but I couldn't be as upset as I needed or as I felt I should be, because I never had that conversation with my client. So that conversation then had to be had. When we're in public, what are you most comfortable with? And after some discussion, and in essentially, my client taking the lead on that conversation, we decided that if we'd seen each other in public, that we would do a head nod. And I had seen her a couple more times in public, and we did a head nod and kept moving. The problem is that if you don't discuss it and something like that happens, it becomes extremely uncomfortable and can actually damage the therapeutic relationship. So one of the things that we do is that we address this head on. So, hey, we're thinking of all possible scenarios, but if I were to see you in public, do you want to acknowledge or not be acknowledged? Understand that I, as a therapist, will never acknowledge you first. If you choose that you want to have any kind of acknowledgement, I will never acknowledge you first, but if you choose to acknowledge me, that's fine. We're not going to go into specifics about the relationship if you choose for that acknowledgement to take place. What do you think it might look like for you and I to have an acknowledgement out in public? And then you construct that together, because again, it protects them as much as it protects you. I don't get embarrassed very easily, but I'm not going to lie. I was quite embarrassed holding a bunch of bachelorette items in the middle of a store in Center City with my client talking to me about all of their problems and concerns. And when I tell you that I tried to redirect this person for 20 minutes, and the way in which I was acknowledged in the store, I thought that there was like a celebrity in the store. And like, I was looking all around like, oh my gosh, what's going on? And then it was a point like, there's my therapist. She's the baddest biatch ever. OMG, I can't believe I see you here. I was like, oh my goodness. The friend who I was with, this has been years now, and my friend who I was with still won't let it down. So yes, you have to talk about it before. Okay. So, a couple of things. Why do clients choose therapy? So, there's a couple of reasons, or a number of reasons why people choose to come to therapy. One is because something is distressing for them. If it's something that's distressing them a lot, this, going to therapy can help to enhance their motivation. It could be that someone else insisted that they come, that they don't want to be there, but their partner, their children, their husband or wife, their boyfriend or girlfriend, their parents, their siblings, cousins, aunts, uncles, friends, coworkers, boss, even court mandates say that they have to come, but they don't want to be there. It happens. Some people really, truly want personal growth and development, that they are highly, highly motivated people. And sometimes it's a combination thereof. In many situations, people may be either externally driven, so an outside person or entity is influencing them to come to therapy, and eventually they seek out the support for themselves. Or it could be that they're doing it both at the same time. Like, I'm tired of being in and out of drug court, so maybe therapy and kind of kicking this habit once and for all is going to be helpful. Solution-focused therapists, they typically refer to clients as one of three things: either visitors, complainants, or customers for change. So the visitor is someone who comes and goes to therapy. These are typically individuals who've been in and out of therapy for many, many years, and they, get what they need out of it for that fleeting moment, and then they stop coming. The people who are complainants, these are the people who consistently find issues with therapy. They may find issues with their therapists, with their agency, with their insurance company, with how much the sessions cost. They're typically going to find a number of reasons why they cannot continue long term. They typically will stay longer than the visitor, but not as long as the customers for change. The customers for change are those people who are highly motivated, who recognize that a pattern of behavior is no longer healthy for them. Their way of coping isn't working anymore, and it isn't healthy, and that for the sake of themselves and those around them, that they want to make changes, that they want to have growth and healing. When you are in the intake session and you are not only gathering information, but you're getting your clients' goals, you have to make sure that they're collaborative, whether that's in the intake or even in therapy. You, as the agent of change, cannot set a goal for someone if they don't believe in it. For example, as I said, I work with people who are pre and post bariatric surgery. So these are people who are having surgery to modify their stomachs to lose weight. I can't tell them if they have not had the surgery yet and they come to me because they need a psychological evaluation. And in some cases, the psych eval, they typically go for a psych evaluation. And if they are found that they need support, that's when they come to me. So I can't tell these people that their goal is to lose 10% of their body weight in 1 month before surgery. That's not realistic. That may not also be their goal. That may be a goal that the doctor set, but maybe their goal is to get healthy. And getting healthy means that they're going to try to lose 5 pounds. They're going to try to modify their eating. They're going to try to increase their water intake. If you can get your clients on board to that goal, they are more likely to achieve it. If you tell a client what their goal is going to be, the clients are probably not going to come back to you. And then A, they've lost out on therapy, or B, if they do come back and they haven't reached the goal that you've set, now they start feeling like they're failures, that they can't accomplish anything, that they're losers. They lose self-concept, they lose self-efficacy, they will lose motivation because it's not something that drives them. So you always want to make sure that you are collaborative when you're coming up with goals. If your client is coming up with goals that are broad, that's okay. You can always help them to funnel that down. So if their goal is to lose weight, okay, how much weight do you think you want to lose? Or if they don't know, say, okay, well, you're at this size now. What size do you think you want to get to? If they're if they're 200 pounds, they want to get down to 100 pounds in 6 months, that might not be feasible. But if they're 200 pounds and they want to get down to 190 and they give themselves 3 months, that's a healthier goal to set. You can always help them to funnel and ebb and flow their goals. You can also take their goals and help them to make it into smaller goals as part of the treatment plan. In cognitive behavioral therapy, one of the ways that you are able to be collaborative is by coming up with what is known as the problem list. The problem list is you ask a client to write down, what are the 3 biggest concerns that you have in your life right now? They'll write them down. And then you can work with them to pick one or all of them, depending on the amount of time you have. And you say, okay, so if your biggest problem is this, whether they write it down or they just talk to you about it. Okay, if your biggest problem is this, how will you know when you have achieved your goal? Okay, this will happen. Okay, so what are some things that we can do between here, where you're at now, and in the future, where it is that you want to be? What are some things that we can do in the process? And then you can help them to funnel down some of their goals. No matter what, even though you have a stance of privilege, being that you're the therapist, both you and the client bring expertise into the room, and both versions of expertise are very important. You have the ability to help them to shift, but your clients have strength. I've never met a person in my 9.5 years of practice who didn't have strengths. Many times they don't see their strengths, or they focus so much on their barriers or the things that hold them back that they lose sight of their strengths. Once you are able to empower someone, and once you are able to show that they are resilient and that they do have the capability and the ability to do things, and that they have these interpersonal strengths, they blossom. It's the most amazing thing in the world to see. When we think about working with clients, we often take this from a learning model. So there are 6 things that we typically do. Number 1 is to quiet yourself and listen. Don't think about what your response is going to be. Really listen to what the client is saying. Really hear what they're saying. Listen to their tone. Hear their pain. Hear their anguish. Hear where they're celebrating themselves. You also want to adopt a helpful and a non-judgmental attitude towards all clients. Again, you will find over time that there are certain clients that you cannot work with. Even the clients that I cannot work with, I don't think that they're terrible people. They're just not people that I personally feel comfortable working with. So I've connected myself with people in a network who I know will be able to work with them. So I make referrals. You may make a referral within your agency. You may make a referral to another agency. People will make referrals to you as well. But you always have a helpful and non-judgmental attitude. I don't fault the people for the action that they've had. I just know that I'm not comfortable working with them, and that's okay. And over time, you learn how to really become comfortable with being helpful and also to minimize your judgments. When you're working with your clients, make sure that you use specific interviewing behaviors to develop positive working relationships with all of your clients. And we're going to be talking about that over the next 2 weeks, about how, sitting with your arms on the side of the chair versus crossed like this makes a huge difference when you're working with your clients. Because if you are, with your arms crossed in front of you, it's a very closed off feeling to your clients, and they may not be willing to open up. Also, depending on your tone, depending on how you talk, will make a difference as to whether your clients feel comfortable speaking with you or not. So there are certain behaviors and certain ways that you set up your office to help support and facilitate collaboration. You also want to collaboratively obtain diagnostic and assessment information. You never do it at the expense of the client. You always get the client buy-in. The client is not comfortable doing the Beck Depression Inventory too. It's okay to say, okay, you know what? We don't need to do this today. Let's take this extra time and let's talk about some of the concerns that you have and some goals that you may have. You can note that in your notes, but the client was not willing to take the Beck depression inventory too. And then you and your supervisor can talk about how you can get the Beck depression inventory to completed at a later time. Apply individual therapeutic techniques. One of the things you will learn as you go through Rowan and you go through your master's program is that you will learn a variety of different therapeutic techniques. You will never be an expert in every single technique, but you will use certain techniques more than others. The model that I use, that I always help to train clinicians on, is what's called an eclectic technique. It's where you are learning different therapeutic orientations, and then you apply different pieces of these different therapies to the client based on where they're at or what it is that they need. Some people might need, more cognitive behavioral direction. Some people may do better with really scripting out their story or utilizing narrative therapy. Some people want things done in a shorter amount of time. Maybe they lack patience. So brief strategic therapy may be beneficial for them. Some people are more emotionally driven. So emotional focus therapy might be something that's a better fit for them. You will learn different therapies. You will find what works best for you, and then you will utilize different snippets from these therapies in an eclectic way to work with your clients. The last thing that you want to do is you want to evaluate client responses to therapeutic approaches and techniques. If a client is not responding to a certain technique, you can try something else. Maybe they're not built for, or they're not ready for cognitive behavioral therapy. Maybe they're more emotionally driven right now than they are about their thoughts and their behaviors. So if you're able to reach them on that emotional level, you can then incorporate aspects of cognitive behavioral therapy. So you will find over time what works best for clients. So close your eyes again. And I want you to think about this for a second. Can you imagine yourself calming down and listening without giving any advice? In the chat box, I want you to type yes or no. Can you imagine yourself calming down and listening without giving any advice? All right. That's honest. I'm working on it. So something for us to think about is that for many of our clients, they seek someone who will truly listen to them, not tell them what they want to hear, not fix them, even though they're coming in to get fixed. For many of our I say that in air quotes, but really for many of our clients, they want someone who is going to listen to them, who's really going to hear them, because that's something that they lack in their everyday life. So to have you be able to listen and not be 10 steps ahead on what therapies they're going to use to work with them on, but you're really hearing what they're saying, that can be huge, especially if you're in this information gathering session and you're now giving their information to someone else, or you're using that information to then work with them at the next session to come up with a treatment plan. So you can read this slide, but this is how you can adopt a helpful and non-judgmental attitude, is what Carl Rogers wrote in 1957. When you think about working with clients, the number one thing that we want to do is to develop a rapport. I'm going to go out on a limb here, but I'm going to say that 90% of what you do with clients is about your relationship. If you don't have a relationship with your client, there's no change that can happen. If your client doesn't trust you, if your client doesn't like you, if your client is not connecting with you, or you have potentially said things, or things have transpired in or out of the session that has caused the client to shut down, or the client is just naturally shut down for a variety of reasons. If there's no rapport, it's going to be very difficult for the client to experience change. And understand that we have a million different flavors of ice cream for a reason. Not everyone is going to suit everyone's needs. There are some situations, however, where even though you might not like chocolate chip cookie dough, all they have left is chocolate chip cookie dough ice cream. So we have to try to make the best out of these situations. Over time and in your training, and beginning with this class, we're going to work on ways that you can increase your rapport building skills. And by increasing your rapport building skills, that can help to produce healthier relationships with our clients. So let's talk for a few minutes about multicultural competencies. We're going to be focusing more on this next week. When we think about multicultural orientation, it is necessary because most therapists, or those in the helping field, or those in the mental health field, are predominantly white. The United States culture is becoming increasingly diverse. And by being competent with different cultures, it helps to facilitate not only more positive outcomes, but it's also more ethically sound. And multicultural competency is an ethical mandate for not only the major agencies that oversee the mental health practices, but for many state licensing certifications and recertifying your licenses. So the 4 multicultural competencies that we will work on together in this class are going to be cultural self-awareness, multicultural knowledge, cultural specific expertise, and culture sensitive advocacy. So when we think about cultural self-awareness, we have to think about white privilege. I am a white woman. I'm a white woman. And as a white woman, I know that I have privilege because I am a white woman. There are some therapists who have a really hard time recognizing their stance of privilege. I can't say that I understand what it's like to experience a racial bias because I've never experienced it, and I won't experience it because of the color of my skin and the stance of privilege that comes with it. However, I understand that there is a privilege that exists, and I work with understanding other racial backgrounds and other ethnicities and national origins, not only through training, but also through asking my clients to help me to understand, or asking my students to help me understand, because I don't understand certain things. And if I say something and it's insensitive, I hope that my students will call me out on it, and I tell my clients to call me out on it too. Because if I am being insensitive, I want to make sure that I learn from it. That is the best way that we can, or at least one of the best ways that we can understand cultural self-awareness. I know that I have a stance of power, but I will do everything in my power to be an ally, and I will do everything in my power to make sure that I am as supportive as possible to other cultures. So when we think about multicultural knowledge, we get this from books and educational materials, life experiences, classes and workshops, but we can get it from other areas too, having conversations with people, students and peers and clients. Not assuming that we know what it's like to be in that other person's shoes, because that person's the expert of themselves. So asking that person to share their story with us so we can have a better understanding of what their understanding has been. Just because they may look a certain way or appear a certain way or act a certain way or, be a certain age, any of these things, we can't assume that because of this, that they have a similar experience to what we read in the book or what we took in a class. So asking the client to explain can be helpful for us. Not only does it build rapport, but it also helps us to get to know our clients better. We also need to have culture-specific expertise. So part of that is going to be forming and testing hypotheses about client culture rather than coming to a premature conclusion. Never make an assumption, y'all. Assumptions are 99.9999999% of the time wrong. Also, there's this notion of dynamic sizing. Your book talks about when you should and shouldn't make generalizations based on individual clients' belongings to a specific culture group. I never do. I explicitly ask my clients, how do you identify? Tell me about your culture. What is your culture like in relation to, who you are? Or how does your culture impact you today with why you're coming to seek some support? We also need to have cultural sensitive advocacy. Microaggressions exist. Microaggressions are things that are brief and commonplace, but it includes verbal, behavioral, and environmental sayings or actions or behaviors or even memes. And while it is often unintentional, there are still some intentional microaggressions that exist. and it harms groups of people. So what do you do when this happens? Well, number one is to call it out for what it is. Number two, if it happens in session with a client, to apologize to them and to ask them, what can you do differently? Or how can you say it differently? And mean it. If you don't mean it, your client knows that. And your client is not going to want to work with you as a result. We also have multicultural humility. And this is where you have these different dimensions. So one is an other orientation instead of a self orientation, respect for others and their values or ways of being, and an attitude that includes a lack of superiority. So really, when it comes to multiculturalism, your client is the expert of themselves and their culture. And while there may be overlap in what you've learned, it's really important to allow the client the opportunity to tell you about their culture, to be able to respect what they have to say, and to check yourself and your status of privilege, should you have any. And just by being a therapist, you do have a stance of privilege, so at least acknowledging that, but that there's a power differential in that privilege. Knowing that because of that power that you have, that you are there to help as an agent of change for your clients and to help them see the strength that they have from their cultural background, to be able to embrace how their culture is a huge part of who they are and what they're about and what guides their values, attitudes, beliefs, and thoughts and feelings and values and norms. Stereotyping does exist. If that were to happen in session, and even in this class, if stereotyping were to happen or occur, it's important that once you recognize it happens at your next session with your client, to apologize for any stereotyping that was made and that it was done in error, and tell them what you're doing to work through it. Work with your supervisors in order to get the support in order to reduce stereotyping. And try not to engage in it, even if it's something like a funny meme or a picture that's on social media. The more that we engage it, the more it will continue to happen. So hopefully this was helpful for you today. And if there's anything that I can add to this multicultural piece, I certainly welcome and encourage it. Over our classes, we will spend more time talking about the multicultural piece. This was sort of the beginning of the foundation. Next week, we're going to talk a little bit more about the foundational aspects of it. And as our class goes on, we're going to talk more and more about how we embrace diversity, how we deal with microaggressions and prejudice, discrimination, and stereotypes, especially not only in the therapeutic setting, but also with the larger society. So I hope that this was helpful. If you ever have any questions or comments or concerns, don't ever hesitate to reach out to me. But I hope that everyone has an awesome week. There is an assignment that's due this week. It's your discussion post. Please make sure that you respond by Thursday at 11:59 p.m. and then you respond to 2 other students by Sunday at 11:59 p.m. Okay? I will also be putting out the video for Chapter 2 soon. So I hope you all have a great week. Thank you for being here, and I look forward to seeing you on Tuesday. Bye, everyone.